My name is Anna Meta Kristensen, and I'm a medical doctor at Bispebjerg and Frederiksberg University Hospital in Denmark. We started collaborating when the trials were ongoing, as we knew that none of the trials were sufficiently powered to assess individual outcomes and lacked robust or lacked data for robust subgroup analysis. And furthermore, the trials had different primary endpoints, and their results were a little bit, divergent. So therefore, we believed and believe that meta-analysis consolidating the totality of evidence from randomized trials on beta blockers were essential. Yes, if we start with the included trials, we included 5 contemporary beta blocker trials: the Spanish-Italian REBOOT trial, the Swedish REDUCE trial, the Norwegian BETAMI and the Danish DANBLOCK, and lastly the Japanese CAPITAL-RCT trial. And all of these trials were investigator-initiated, open-label, randomized superiority trials. And all of the trials had independent adjudication of their endpoints, except the REDUCE AMI trial. And all of these trials included patients with a recent MI with either mildly reduced or preserved LVEF, except the REDUCE MI trial, which only included patients with preserved LVEF. And these patients had no indications nor contraindications to beta blocker therapy. And they were randomized to either beta blocker therapy or no beta blocker therapy. So that's a little bit about the included trials. And if we focus on the patient population of this meta-analysis, we included a total of 17,801 patients from these trials. And the median age was 62 years. 21% were women. And a little bit less than half of the population had had a STEMI. And if we look at the patients randomized to beta blockers, then 47% were treated with bisoprolol and 46% with metoprolol. And maybe it might be important to add that the vast majority, 96% of the patient population, were revascularized. Yes, in this patient population was patients with a recent MI and preserved LVEF. And we found that beta blockers did not reduce the incidence of a composite of death, MI, or heart failure. The hazard ratio was 0.97 and the p-value was 0.54. The results were consistent across the individual components of the primary endpoint, across the other endpoints, across the trials, and across pre-specified sensitivity analysis. And if we look at the subgroups included in the trial, they were pre-specified subgroups, we found the same results. There appeared to be neither benefit nor harm in any of the included subgroups, including age, sex, type of MI, previous beta blocker therapy, etc. That's a very important question, and I think I need to stress that all patients should be assessed on an individual level, and our findings does not support routine withdrawal of beta blockers for all patients with preserved LVEF after MI. Actually, a substantial proportion of patients were ineligible to be included in the trials because of an existing indication for beta blockers such as atrial fibrillation, heart failure, uncontrolled hypertension. However, we believe that it is important, especially in this era of increasing polypharmacy, to evaluate whether we should be treating patients with all of the medication that we do. And our findings does not support routine beta blocker therapy to all patients. And to help guide the clinicians, we're actually also currently working on sub-studies focusing on patient-rated outcomes and physical activities, etc. Together with our recently published meta-analysis on patients with mildly reduced LVEF, I think I believe that this study provides valuable insights to inform clinical practice and guideline recommendations on beta blockers after MI. And the beneficial effects of beta blockers in patients with mildly reduced LVEF aligns well with the current recommendations and the recommendations for patients with heart failure. But our findings does not support routine prescription of beta blockers for all MI patients with preserved LVEF. But ultimately, it's up to the clinical community and the guideline committees to make recommendations that balance safety and efficacy and patient-rated outcomes.